Please carry on, Dr. Jizeeri.
Yeah, thank you so much again for the kind invitation. So I'm going to talk about the role of anatomical and functional testing for chronic coronary syndrome, and how can we choose among these patients. And I'll try to bridge the gap between the clinician and imagers. I have no disclosure related to this talk. Now, I will start with this case. This is a 61-year-old female with diabetes, hypertension, hypercholesterolemia, and osteoarthritis. She had recurrent episodes of chest pain on exertion with shortness of breath. Her profile revealed a morbidly obese lady with a BMI of 59. Blood pressure is out of control. She has unremarkable clinical examination. Otherwise, her labs were also a bit off. Her hemoglobin A1C was at 10.3%, which is her standard would be around 7. She has 3.6 of LDL, and creatinine was normal. Now, why do we care about chest pain? Chest pain is among the commonest presentation in our ER or even ambulatory care visit. 7.5% of patient of visits to emergency room department in the US are related to chest pain, and 3% are in the ambulatory care visits are related to chest pain. Now, this may not seem a lot, but if you put them in the numbers, it is 7 million visit in ER and 2.6 million visit in the clinic. That's a total of, a total of 10 million visits. And you could imagine the impact of that on our healthcare system. Now, how do we risk stratify her? There are two questions. Does she need further testing? And what test should I order? This is how we as a clinician usually pause the question and then send the patient to imagers like you in order to help us to identify the cause of this patient chest pain and probably understand her risk in terms of cardiovascular diseases. Now, the first question, does she need further testing? And this usually goes to the pre-test likelihood of coronary artery disease. And luckily, over the past 30 years or so, we have a lot of risk model that tell us the likelihood of the disease. It started with Diamond-Forrester classification, which was published in the late 1970s, and it is a very simple approach. We look at the age of the patient, we look at the gender of the patient, and we look whether the patient has typical anginal chest pain, atypical anginal chest pain, or non-cardiac pain, based on the 3 criteria. And this will plot the patient into a risk of either low risk, high risk, or intermediate risk. Later on in the early 1980s, we have Duke clinical score, which integrated a bit of more information regarding the patient, including the ECG, hypertension, and diabetes. And it has similar approach, very simple as risk assessment in order to identify the likelihood of a patient coming with chest pain to have coronary artery disease. The problem of these studies that these 2 risk scores that they are very old and they are dependent mainly on coronary angiography and autopsies, and they have a bit of a different definition in terms of Duke framing. The Diamond-Forrester score consider 50% as significant stenosis, and while the Duke score considers 75% as significant stenosis. As you can see, there are also different range in terms of identification of patients in terms of low risk, intermediate risk, or high risk. Now, later on, we have the consortium clinical score, which has 3 scores: the basic model, the clinical model, and extended model. The basic model is similar to Diamond-Forrester model. The clinical model add diabetes, hypertension, smoking, hyperlipidemia, and body mass index, and the extended model have add coronary calcium score. Now, as you can see, the problem with this score, it is a bit comprehensive and may be tedious to go around doing all of these numbers in order to identify patients that what are the likelihood of patient to have coronary artery disease when he or she presents with chest pain. We have also the confirmed registry risk score. This is a history-based risk score derived from confirmed registry, which is the CT registry. And again, the problem with these registries is that they have a lot of parameter to look at. And in a busy clinical practice, it may prove difficult to put all these together before we can identify the likelihood of the disease of the patient. The updated Diamond-Forrester classification or ORISCO score is an updated form of the original Diamond-Forrester classification. It included people more than 70, and this time we have patients that have coronary angiogram, CT angiogram, with a better algorithm in order to assess the risk. But the beauty of it that it adds also patient presenting with shortness of breath as a angina equivalent presentation. And as you can see, the numbers are a little lower than those in the original Diamond-Forrester model, because now we have a better algorithm and we included cardiac CT. The European Society of Cardiology 2024 guidelines came up with the an updated form of the ORISCO score that I just showed, and this time they added also the risk factors in order to better refine the risk of patient before decide whether they will or will not need risk assessment. Now, if you go back to our lady, you will see that if we use the classical Diamond-Forrester model, her risk is 51%. If we use the American College of Cardiology Diamond-Forrester model, it will be 27%. If we use the confirmed registry model, 17%. If we use the risk factor weighted clinical model, it will be 17%. If you use confirmed history score, it's 21%. And if we use the updated Diamond-Forrester model, it will be either 11% if we do not use the new European recommendation, or 14% if we use a European model. So most of the time, we usually try to risk stratify those patients that are higher than 15% likelihood of the disease. So one would ask, why not invasive coronary angiography? We just go to the gold standard, answer the question fast, and probably do this in a better way. The answer comes from this study, which is from the NCDR registry in the US, where they look at 2 million people referred for coronary angiogram, and when they excluded people who had prior MI, prior PCI, prior CABG, and those patients going for transplantation or going for valve surgery, or those patients who are presented with acute coronary syndrome, they end up with almost 400,000 patients, and only 37.6% of them have obstructive disease. So more than 60% could have been risk stratified otherwise without subjecting the patient to the risk of invasive coronary angiography. So now that we established that this patient needs a test, what test should I order? And in that term, 3 questions comes to mind. And those can be posed either by the imager or by clinician. The first question is, why does my patient have the symptoms? The second question, what can I offer my patient to decrease his symptoms? And the third question is, what can I tell my patient about his future cardiac events? Now, if you think of a chest pain, based on the diagnostic and risk stratification, we could go for either anatomical evaluation, which could be invasive, like coronary angiogram, or non-invasive by CT, or we could do for functional testing with stress ECG alone, stress echocardiography, nuclear imaging, which could be SPECT or PET, or stress CMR. And these are basically the overall view of how can we risk stratify my patient in order to get a diagnosis. Now, if we look at the diagnostic accuracy of these tests, this is a meta-analysis looking at per patient diagnostic accuracy on the left and per segment on the right. As you can see, PET and MRI lead the group with a very high diagnostic accuracy that surpasses the other modality. But in general, all of these have their advantages and disadvantages when it comes to risk stratifying patients. So if we go to each one of them, if you look at the test, CT angiography, you could see that we cannot provide a functional testing. We may add a pharmacological stress test in order to elicit ischemia. It has some radiation, definitely it has a contrast. Exercise stress test alone, it can be done with exercise. We don't need pharmacological stress testing. It has no radiation, doesn't need contrast, but unfortunately, it is very limited. It has very limited diagnostic accuracy of around 70%. The butamine stress echo could be combined with either exercise or pharmacological stress testing. It has no radiation, it has no contrast that affect the kidney, of course, but it has its own contrast that can be used. SPECT, it can be combined with both exercise and pharmacological stress testing. It's associated with significant radiation, and there is no need for contrast. But probably now with fluorperidas, we can do some exercise stress testing. However, it's mainly pharmacological stress testing. It has a better radiation profile, and it has no need for contrast. And CMR, we cannot do exercise. We can do pharmacological stress testing. It has no radiation. It has its own contrast, which is gadolinium-based contrast agent. Now, so basically, when we talk about the main two modality out of the non-invasive stress testing, we look at CTA, which is coronary CT angiogram, versus functional testing. And there are two studies that looked at the differences between these two modalities, which is a Scott-Hart study and PROMISE study. Now, starting with the Scott-Hart study, it's a pragmatic study of 4,000, almost 4,200 patients. They have low to intermediate likelihood based on the risk models that we've seen. It's pragmatic randomization based on the choice of the treating physician, and it compared a standard of care versus a standard of care plus a CT angiography. And this is the standard of care, including treadmill exercise stress testing for every single patient. The mean age was 57 years of age, good representation of females, probably diabetic are underrepresented. And as I said, all these patients had exercise stress testing and then randomized whether or not to have CT angiography. The outcome was very promising. Patient who has CT angiography has better chance of lower, well, see, the patients who had CT angiography has lower chance of cardiovascular death or myocardial infarction or stroke. Not only this, but patient who had CT had a better reclassification of diagnosis, change in the investigation, and change in the treatment. So very important in terms of changing the overall management of this patient. This has also been seen in 5 years follow-up, where again, patients who had CT angiogram has a lower chance of death from coronary heart disease or non-fatal myocardial infarction, and a better chance of, and less chance of non-fatal infarction compared to standard of care. Now, one would worry that this approach may lead to increase in the downstream utilization of testing, and this was not the case in patients who underwent randomization in Scott-Hart study. So you can see both invasive coronary angiography and coronary revascularization were similar in both groups, whether one was assigned to CT angiography versus standard of care. The PROMISE study was done on the other side of the Atlantic in the US and Canada. It included 10,000 patients, almost double the number of Scott-Hart. Again, low to intermediate likelihood, pragmatic randomization, CT versus functional testing. Around 70% of patients underwent a nuclear stress testing, a quarter underwent a stress echocardiography, and only 10% underwent exercise ECG alone. The primary composite endpoint was death from any cause, non-fatal myocardial infarction, hospitalization, and major procedural complication. Mean age was 61, good representation of females and better representation of diabetics. And to our surprise, there was no difference in those outcomes whether one have choose initially to go for anatomical testing or functional testing. So completely the opposite of what Scott-Hart have shown. Again, likewise, PROMISE trial demonstrated that patients who underwent CT have a higher chance of cath, a higher chance of revascularization, and of course, lower chance of having obstructive coronary artery disease of cath. So exactly the opposite of what Scott-Hart have shown us. One thing that I like about PROMISE trial, that it has demonstrated to us that men and women are not alike when it comes to coronary artery disease. It showed that women have much higher positive stress testing, functional testing, while men have much higher CT abnormality. But interesting enough, when it comes to outcome, if a female has a positive CT abnormality, the chance of that lady having worse outcome is much, much higher. And this tells us probably that women have more endothelial dysfunction compared to men, and coronary artery disease, obstructive coronary artery disease that detected by CT probably is a very advanced phenotype in women, and that's why they have much higher outcome there. So why is the difference? First of all, every single patient of Scott heart has an ECG, and therefore if I see an intermediate lesion and the exercise is normal, I wouldn't send this patient to coronary angiography. Only 9% of patients of a Scott heart study have coronary artery disease, and the majority of these of events happen in those patients. Furthermore, Scott heart also imply a lot of preventive measures in those patients to have CT, and those patients who did not have CT were not recommended to have a preventive measure such as a statin and lifestyle modification. One final thing, Scott heart had lower chance of patient of typical and non-anginal chest pain compared to PROMIS, almost 1/3 extra. So probably PROMIS represent a more advanced patient with higher risk compared to Scott heart, and this is why we did not see the same presentation or same outcome that we see from Scott heart. Then one has to remember that the ischemia trial have also demonstrated that those patients with ischemia, with moderate to severe ischemia, do not do better if we use invasive strategy, and therefore one should think of doing in non-invasive stress testing, which is ischemia related rather than anatomy, without the fear of having missed a chance of giving the patient a better outcome. Now, what does European guidelines say? European guidelines say that if the patient has very low likelihood of the disease, no further testing should be done. The patient has low likelihood of the disease, then probably CT is better. But as higher and as we go higher and higher in the likelihood of the disease, then one would probably choose functional testing. The American have almost the same recommendation. They consider younger patients with low likelihood to have better served with CT, while older patients with higher likelihood of the disease should have functional testing. And of course, if you are suspecting scar, then one would consider PET scan or cardiac MRI in order to further evaluate viability on the same setting. The arbitrary number of age is 65. However, this depends again, maybe modified based on your local expertise, because some of the time, and patients who have more prevalent of the disease, you could see calcification in a younger age, and you probably choose another test other than CT, because the significant calcification will preclude accurate assessment of obstructive disease. Now, what test should I order if we put things together? If you have suspected coronary artery disease, you will look at patient characteristic, likelihood of the disease, and availability of the expertise. Then if you are looking for rule out strategy, basically rule out the disease and the likelihood of the disease is very low, then CT is your first choice. But you have to remember of coronary microvascular dysfunction. If you want to rule in the disease, so your likelihood of the disease is there is high, but you want to know whether it is obstructive or not, then one would ask himself, is the ECG interpretable? And if it is yes, then exercise, and the patient can exercise, then exercise stress testing with combination with myocardial perfusion imaging. If the patient could not exercise, then we have to resort to pharmacological myocardial perfusion imaging, which can be done with these modality, echo, SPECT, PET, and stress MR. If the ECG could not be read, then obviously we go directly for pharmacological stress testing. Now let's go back to our patient. This is her ECG, and it can be interpreted as you can see. And so all of these are options. She cannot exercise, so probably exercise stress test cannot be done, but we can do nuclear MPI, deep stress echo, stress MR, and CT. She is big lady. She has a BMI of almost 59, so nuclear stress test can be done, but deep stress echo, stress MR, and CT may not be a good option. She is obese. Then SPECT, between SPECT and BET, we know that BET does a better job there. And this is her BET MPI, which showed normal, I'm sorry, I went fast on this, showed normal perfusion, as you can see here, good function with augmentation with exercise, good myocardial flow reserve, and overall, with this patient, pain was not cardiac in origin. So if we want to put this thing into summary, risk assessment in chronic coronary artery disease, there is a spectrum. I would probably start by getting the pre-test likelihood of the disease. If the pre-test likelihood of the disease is less than 5%, then probably should not do anything. We just reassure the patient. If the likelihood of the disease is less than 50%, so we are interested in roll out strategy, and the CTA is the best because CTA has the best negative predictive value of almost 100%. If I know that the patient has a disease, but I want to see whether it's significant or not, and this is most commonly happen in patient of more than 50% likelihood of the disease, then I will choose MPI. And one has to remember that either one of them could lead the other. And remember that in those patients who are at very high risk or very likelihood of having intervention, cath should be probably the best option. So in conclusion, ladies and gentlemen, non-invasive tests are versatile tools in evaluation of patients with known and suspected coronary artery disease. The choice of the test depends on patient profile, availability of the test on your locale, advantage and limitation of each test in regards to patient characteristics, local expertise. And finally, I want to share one final thing, is that in ischemia trial, where moderate to severe ischemia before enrollment were proven, 16% of subject has no obstructive coronary artery disease, and 52.6% of excluded patients have no obstructive coronary artery disease. So a lot of patients who were having significant ischemia did not have obstructive disease, and that should increase our awareness of ANOCA and INOCA, which will be my talk tomorrow, inshallah, if I didn't bore you today. And with that, I thank you for your attention, and I'll be happy to answer any questions.